Closed treatment of sternum fracture. If the fracture is non-displaced and stable, closed treatment is initiated. Braces or splints are not used. The patient's activity is modified while the fracture heals. Closed treatment of ulnar styloid fracture. The physician treats an ulnar styloid fracture with a cast or splint. No manual manipulation and no incisions are required. Closed treatment of coccygeal fracture. For closed treatment of a coccygeal fracture, the physician will prescribe bed rest to alleviate symptoms. Sitting on a rubber ring may also lessen symptoms. Closed manual manipulation may be performed as well. Closed treatment of sesamoid fracture. The physician treats a fracture of a sesamoid bone in the foot without performing any open surgery. X-rays confirm a fracture of the sesamoid bone. The physician places the foot and ankle in a splint, brace, or cast to protect the bone while it heals. Closed treatment of greater trochanteric fracture, without manipulation. The physician treats a greater trochanteric fracture without manipulation. The fracture is not displaced and may be treated with skin traction while in wide abduction. Other treatments include a spica cast applied for 6 weeks or protected weight bearing with crutches for 4 to 6 weeks. Closed treatment of patellar fracture, without manipulation. Closed treatment of a patellar fracture is indicated when there is 2 mm or less displacement, separation, or step-off. X-ray determines any displacement. The leg is placed in a long leg cast or splint to keep the knee immobilized for 3 to 6 weeks. Closed treatment of intercondylar spine, S, and/or tuberosity fracture, S, of knee, with or without manipulation. There are 3 types of fractures of the intercondylar spine and tibial tuberosity. Types I and II of the intercondylar spine and type I of the tibial tuberosity are typically treated in a closed reduction. If the fragment appears stable and is not displaced, no manipulation for reduction is needed. If the fragment is displaced, reduction may be achieved by extending the knee. The knee may also be aspirated. A splint or a locked, long leg knee brace may be used for 4 to 6 weeks. Closed treatment of mandibular or maxillary alveolar ridge fracture. The physician stabilizes and repairs a fracture of the mandibular or maxillary alveolar bone without making incisions. The physician moves the fractured bone into the desired position manually. The fracture is stabilized by wiring both the involved teeth and adjacent stable teeth to an arch bar. Another technique utilizes dental composite bonding of both involved and stable teeth to a heavy, stainless steel wire. A customized acrylic splint may be used to stabilize the teeth. Intermaxillary fixation may also be applied.